Hi, Dr. Krishnan. Thank you for joining us here today to talk about Rotorax. Really want to ask you some questions about your experience and how you've incorporated the device into your practice. So, just to start out, in your practice, what is your signal to use Rotorax? Is it something you are always going to do, or is there something that you're specifically seeing in the angiogram? Really, how do you know it's the right case for Rotorax?
Well, I think Rotorex is a very flexible device, and it has a wide range of uses. Generally speaking, I mean, it is a go-to atherectomy for instant restenosis and any sort of thrombotic lesions, or anything in which we're suspecting a significant amount of plaque burden mixed with mixed morphology plaque. Generally, I think it's more important to know when not to use Rotorex. And I think when you should not be using Rotorex is in heavily calcified lesions. And I think you should not be using Rotorex in any lesions below the knee. I think those are the two areas where you should not be using Rotorex. In our experience, we've done it in all other forms of lesions without a problem. And so it is a very flexible atherectomy device. So, I think the angiogram pretty much dictates where it can fit in, where it can't fit in.
So a couple follow-up questions to that. Is there any tactile feedback that helps you understand if it is more of a thrombus lesion or heavy calcified?
Well, heavily calcified, I think any sort of angiographic calcium that you see, I think, especially in your beginning days of using Rotorex, I mean, you should stay away from it. As you become more experienced and more understanding of how the device and its nuances, then I think you can go ahead and use Rotorex if you justify that the patient is not heavily calcified. But thrombus wise, I think depending on either the way the wire crosses, if it's a very easy cross, whether after you cross the lesion, you find that if you do an intravascular ultrasound, there seems to be some thrombus within the vessel. I think those are the things that you can use. I mean, angiographically, thrombus is very difficult to tell unless you have a meniscus that you see very clearly. Generally, these are long segment, lesions with mixed morphology, and thrombus will play a role in these lesions. So anytime I feel that I have something I need to clear out and also get the benefit of both atherectomy and thrombectomy, I tend to use Rotorex.
That's great. You mentioned IVUS. Is that something that you're doing on every case prior to Rotorex, or how often do you incorporate that in your practice?
No, I mean, I think the role for IVUS in peripheral interventions is not really clearly defined. I think there's a growing body of evidence that says that it may, improve our outcomes, but it's really, I still think you need a lot of data to support that. We use IVUS when we're uncertain of what we're seeing, and I think to more identify any sort of confusion that we may have, or clarify that for us. So those are the times that we tend to use IVUS.
Great. So you mentioned Rotorex and ISR. Can you elaborate a little bit more on how you use it and the outcomes that you see,
Well,
and why you choose
I,
Rotorex for it?
Well, it's lacking randomized controlled data, obviously, like laser, but in a practical use perspective, and I know there's a lot of experience in Europe as well as here. I think that the effect on ISR because of the mixed morphology of both restenotic and thrombus underlying the ISR, we like the larger device when we have a more of a long lesion and a larger burden of plaque that we need to remove, but that involves going with a larger sheath. But I think it's worth doing that, and I think the results you get are phenomenal. I think that you embolize with everything, and I think you can embolize with Rotorex as well. So it's not a anti-embolism device.
So you've mentioned a little bit about your technique and ensuring that you have adequate flow and pulling the device back and potentially flushing it. How many passes do you typically take with Rotorex?
I think it varies. I mean, if there's good flow within the device, I think technique is very important. You have to go very slowly and be very methodical with your advancement of the Rotorex. I don't believe that you should cut backwards. I think it's only a forward cutting device. So I think that those are the things that are very important. Slow and steady, and watch the flow. The other thing we look for is grinding of the device. If there's a lot of grinding of the device, so it's both tactile, it's auditory, and it's visual. So if you're having a lot of resistance as you push, and it's shown by the device not moving on the screen, as well as you see grinding, then I think you need to pull the device back and go slower, allow the device to work, and then obviously make sure that you're having flow, because if it's grinding, then you can obviously have buildup of, lack of a better word, crud within the system. So you need to make sure that's draining as well. But to me, you can make as many passes as you need if you follow good technique.
What advice would you give to a new user of the device?
I think pick your cases. I think case selection is very important. Have your BD rep there with you to talk about the nuances of the device. Pick the brain of a colleague who has used the device. How can you say, more often than you? And I think it's all about picking the easy ones first, understanding how the device works, and then going ahead and doing the procedure and building your confidence with the device. I think the nuances of the device will show itself after even 2 to 3 cases, but I think the principles are simple. One, make sure there's flow within the exit port, or the fluid port, as I would call it. Second, I would use a filter if it's a very long or mixed morphology plaque. Don't expect Rotorax to be a miracle and remove and prevent embolization. It's going to happen. Third, be very methodical with your process. Make sure you go forward. You listen to auditory, visual, and tactile feedback, and then go ahead and get the case done.